So, US guided anastomosis is the title of my lecture. So, these are my disclosures. As all of you have seen in the past few years, we really did have a big festival in US guided drainage. All these new devices developing and all these new procedures that has been done and developed allows us to go to areas that we have never dreamt before. So going from biliary drainage, we can now go through the stent and go into the bile duct and perform a cholangioscopy. We can go into the gallbladder, do all sorts of things to the gallbladder, not just only stone removal. We can drain afferent limbs, and after drainage, we can even use the stent to access a hepatoduodenostomy, for example. And of course, as Vinay has mentioned, US gastroenterostomy is, of course, another very exciting development in our area. So in the Asian US group, which Vinay and I have really contributed a lot in almost the past 10 years, we were one of the first societies to publish these guidelines on interventional US. I was responsible for pseudocyst drainage. Vinay was responsible for biliary drainage. And Kyoda Sensei was responsible for PD drainage. And Professor Yasuda was responsible for celiac plexus ablation. So we did use a lot of hard work to produce this guideline because it almost took us 5 years. But I think at the first society to publish this, and I think it is being quoted quite widely, especially in the West, which I think they are really just picking up with all these interventional procedures. So for this, we are quite proud, and I thank Vinay a lot for his efforts in contributing to this. When we look at the evolution of procedures, I think we all know that in the US it's particularly prominent because you would see all these experts develop all these amazing procedures. And then even with like bile duct drainage, it was described almost 20 years ago, but only now that it is becoming more and more popular. But with all these novel procedures, you really need some pioneer to navigate all these unknown waters. And when they have learned all these from trial and error, then we can start to popularize the procedures, making these procedures lower risk and being acceptable to the wider public, making it easy to learn and also standardized procedures to teach. So I think now we are moving more towards the popularized part. A lot of procedures have been developed. Guidelines is out to standardize procedures. And now we are trying to popularize these procedures and see where it stands in terms of the day-to-day management. When we talk about US guided anastomosis, it's very different from a surgical anastomosis because in surgery, we were taught, when we were taught how to perform anastomosis, we need to look at all these issues like the organ, blood supply, tension, local factors, general factors. But when we think about US anastomosis, it's a very different animal. Of course, we need to think about the organ. We don't think so much about blood supply or tension or local factors. We need to think about devices. We think about the route in which these drainage will go through and what are we trying to do? Are we just performing drainage or we actually want access? And if you think about ES anastomosis, it's really, on paper, it seems to be quite simple because you just want to put in a scope, puncture the adjacent organ, place a stent, and then that's it. But when you actually do it, there are many issues that you need to overcome. It's a non-adherent organ. It's very mobile. There's a risk of stent migration, leakage, and pneumoperitoneum. So throughout the last 10, 20 years, a lot of effort has been put into to overcome these issues. And I'm happy to say that a lot of these issues have actually been overcome. So I think we are really entering a prime time to really try and disseminate the technique. LAMS is pivotal to the development of US-guided anastomosis. These are the two main types of LAMS that is on the market, Axios and Spexis. They both have a specific design where there's an anti-migratory flange. They have a very short distance between the two flanges, and they have a large lumen, allowing a 1 centimeter or up to 2 centimeters diameter. So really allowing the scope, food, and everything to pass through. Also, we are seeing many newer devices coming out this year. This is really just showing us that industry is becoming more and more receptive to the need to develop these US-specific devices and making the whole procedure a lot more enjoyable, safe, and easier to learn. And most important of these development in the recent years is the single-step device, because it makes the whole creation of the anastomotic procedure much more easier. So it just combines all these different steps into just one single step. So for me, not only it is easier to perform, it's a lot easier to teach. And students are actually a lot easier to feel a lot easier to learn, because you don't have to struggle with all these different steps. But having said that, it's important to have a grasp of these conventional technique, because sometimes when we go into trouble, we will still need to fall back on these techniques. And the importance of US-specific devices include reducing the difficulty of the procedure, reducing the risk of legal and adverse events, shortening the procedural time, and also decreasing the learning curve. So these are very important in terms of US-guided interventions. In terms of anastomosis, basically any organ that is adjacent to your scope, we can basically drain it. So we can now drain the common bile duct, perform a hepatogastrostomy or hepatoduodenostomy, pancreatical gastrostomy, pancreatical duodenostomy, cholecystoduodenostomy, so cholecystogastrostomy, and of course gastroenterostomy. So anywhere close to the GI tract can be anastomosis. We can perform anastomosis. And more recently, we have also seen reports on large bowel, small bowels with the luminal pulsing stents. So it is getting very interesting in terms of this area. In terms of PFC drainage, I think I'm sure most of you here have heard multiple talks on this area. There are the Dutch pancreatitis group has been leading this area, and most recently in the ESG days, they presented a randomized trial comparing plastic stents versus luminal pulsing stents. So the beauty of these stents, of course, allows us to perform a single-step puncture and drainage. So this is a hot Spexis stent, which we can also perform direct insertion with the device, followed by an opening of a flange, which needs to be performed by an assistant, unlike the Axios. But the technique is similar, so you just open the stent, and afterwards you pull back the stent, and then open the proximal flange. So the whole procedure becomes very pleasant. You can finish it in 5-10 minutes. And if you need to, you can also place an additional plastic stent through the luminal pulsing stent. What's also interesting is the accessory devices that has been developed. So this is the endorotor. It was a mucosectomy device where the tip has a rotatory motor, and it allows us to suck the tissue and cut through all the dead material. It's quite useful because sometimes I'm sure you have experienced that during necrosectomy, all this gluey stuff is very difficult to remove. So with the enterotor, it makes it a lot easier. Of course, you may question the safety because if you bit a bit of a vessel, of course, there's always a risk of injuring the vessel and causing bleeding. But this is making necrosectomy a lot easier. In terms of biliary drainage, I know we all know that the current indications include failed ERCP, but a lot of talks recently on USBD to replace ERCP. Rationale is that we can avoid placing a metal stent across the tumor, and as a result, we can increase the stent patency, reduce procedural time, and no risk of pancreatitis. Of course, there are definitely some advantages. This is a CDS by my trainee, the first of CDS of hers. I wanted to show you this because I want to show you how these devices improve the ease of learning the procedure. So she's accustomed to FNA, so puncturing the bile duct was not a problem. I was helping her with the guide wire manipulation. So once the wire is in, we pull out the needle, exchange with the axials. So she did some work in animals, so she knows how to push in the device. And after the stent is in the bile duct, then the distal flange is being opened, followed by pulling back of the axials and then opening the proximal flange. So in her first procedure, she was able to finish this in 10-15 minutes, and she was very, very happy. But also really makes a difference in the whole learning process. And of course, if it's a smooth procedure, definitely a lot of advantages in terms of patient outcomes. So with this device, we also started this randomized trial. We've actually completed it and presented the initial results in the recent ESGE Days conference. So in short, this is DRAMBO, Drainage for Malignant Biliary Obstruction Study. So 83 patients in the CDS arm, 81 in the conventional ERCP arm. Technical success is significantly higher with CDS. Clinical success was comparable. Procedural time significantly shorter. 30-day adverse events is similar. Currently, we are still following up our patients, so we haven't seen any difference in 1-year outcome. Our last patient recruitment was in, I think, January. So maybe still another year to go before we really see the results. But at least I think we are seeing some advantages of the CDS procedure. And you may wonder why the technical success was a lot higher. I think in the CDS arm, most of the patients, even with duodenal obstruction, they were able to perform CDS, but with ERCP, it's either due to a duodenal obstruction or failure of cannulation. In terms of stent dysfunction, we don't have the long-term results yet. But it seems that the ERCP arm has more tumor ingrowth, but CDS arm, we are seeing slightly different problems, like partial migration, foot impaction, and impingement on the opposite wall. So still, we need to follow up the patients a bit more, but very eager to know whether there are any difference in terms of the long-term patency. Gallbladder drainage, I think you all know this is one of my big research areas. And for me, it's really a logical progression. If you look at the development of ERCP, going from T-tube to ERCP, and for gallbladder drainage, going from percutaneous open cholecystostomy to percutaneous, and then now endoscopic. So again, nowadays with this cochlear enhanced device, we can perform direct puncture quite easily. Again, teaching is a lot more pleasant because the trainee feels like the procedure is much easier to grasp. This gallbladder was strained by a hot spike stent. And this puncture is the same, and a distal deployment followed by proximal deployment of the proximal flange.
Anthony, you have 2 more minutes.
So we have published a lot in this area. Thank you. Yeah, I'm almost done. And meta-analysis showing definite benefits of EUS GBD. And most recently, a drag study published in Gut showing a reduced 1-year events, acute cholecystitis, reinterventions, readmissions. So definitely in high-risk candidates, EGBD is the preferred modality. And now we are moving towards surgical candidates. So this is a propensity score analysis comparing EGBD versus lab chole. You can see there's not much difference in every single parameter, even in patients with recurrent cholecystitis and Puri events. So we've just finished a recruitment of a prospective study of 30 patients. So we will see how this does in the longer term. So finally, US-guided gastroenterostomy. There are a number of different procedures, including GJ, edge procedure, aphen limb drainage. With the US gastroenterostomy, you have all seen me performing the EPAS procedure. We know how it's done, so I'm not going to show this a lot of this, but basically we have used this balloon, 2 balloons to occlude a segment of small bowel, and then perform direct insertion of the axial stent. So it's a very stable platform. And again, it's very safe. So again, most important in all these EU interventions is being the safety. And the outcomes are suggesting that US gastroenterostomy may be associated with high clinical success, less adverse events, and less reinterventions. And right now, we are performing these randomized trials. We're up to 30 patients now. So hopefully by the end of this year, we can complete this study. And in the interest of time, I'm not going to show this, but this is basically showing you that we can perform a aphen limb drainage and use this as a portal to access a obstructive HJ at the end. And procedure like this, where the scope is going through to the HJ, performing bilateral metal SEMs. So in conclusion, I think it's definitely prime time for US-guided anastomosis. There are new devices making the procedure easier for everyone, and also opening exciting new opportunities in endoscopic therapy. And nowadays, we are receiving more and more data in RCT to confirm the benefits of these procedures. So thank you for your attention.
Thank you, Ideal Care, for giving this opportunity and an excellent overview by Dr. Anthony about the anastomosis in various indications, US guided. And what I know is I'm going to talk, I'm not going to present the slides, I'm going to talk 5 minutes without slides. There are certain indications, like when we talk about the pancreatic fluid collections, I think is well standardized procedures, accessories are there, lot of literature is available, and EUS is now standard of care for the pancreatic fluid collection. And so in the biliary drainage when the ERCP fails. I would like to touch upon 2 things. One is EUS-guided gastroenterostomy in the gastric outlet obstruction and the gallbladder drainage. As we know that gallbladder drainage frequently occur in the periampullary carcinoma, and in India, the carcinoma gallbladder. In 20 to 25 years before the people go for a surgical, either a lap chole or open gastrojejunostomy, but I think because surgery is costly, time-consuming, patient is morbid, and they have got an associated adverse effect like a wound infection. And after that, endoscopy is the standard of care, putting a enteral stent endoscopically. But in the last few years, what we have learned, because of the better chemotherapy, patient has a more longer life, and because of that, the patient comes repeatedly with the enteral stent blockage. And what we need is We learn from the surgical colleague to create a stoma between the stomach and the jejunal loop endoscopically, which is less invasive and associated with the early recovery. So I think what we require is a better instrumentation, better technique, standardized technique, along with that more data about the gastroenterostomy. And my feeling is what we require is a better scope, because linear echo endoscope has its own problem. The forward wing echo endoscope will be better because the diameter of the channel will be bigger. Number second, the force apply with the forward wing echo endoscope will be better. That is my thought process on this. Second important thing is what we require is a large stoma. With the available stent, we can give 16 millimeter or 2 centimeter. We require a large stoma, so we have to create a bigger stent which can give a bigger stoma. And third important thing is identifying the jejunal loop. Many of the time there is an intervening colon. So we should develop a method so the puncture jejunal loop we should be able to identify more precisely, so risk of complication will be less. If you look at the literature, the clinical and the technical success is from 85 to 100%, but the complication is also up to 30%. So what we require to develop an instrument, develop a standard technique where the complication risk will be less. And now what I want a technique, I want a stent which should be deployed by a single operator in a single session, biodegradable stent, so there is no complication of the long-term stent blockage. The stent should be act for a few weeks to a few months and create a bigger stoma. And we require a larger diameter of anastomosis, and we can fix up the desired loop which we want to intervene, we will be able to do it. This is regarding the gastroenterostomy. Similarly, when we talk about the gallbladder drainage, the concept is same. We require a better technique, better stent, so complication will be less, and we require more data so we can compete with the percutaneous gallbladder drainage or surgical gastroenterostomy or endoscopically placed enteral stent. We can give the better data, so it should be included as a standard of care, as EUS is standard of care for the pancreatic fluid collection.